lot of the pathology that you're going to need to know in gyne, of course, is going to be related to the menstrual cycle, right? Heard about neoplasms yesterday, but most of what you're going to see on a day-to-day basis in the office is going to be people having period problems, right? Okay. So if you have someone that comes in and says, man, my periods are they're just not right, they're not normal. The topic we're going to talk about today is the lengthening of the cycle and then eventual no cycle. Okay, so oligomenorrhea, periods that are longer, they take 35, 40, 60 days to happen, and then eventual amenorrhea. Question?
I thought, doesn't oligom normally mean less?
It means less frequent. So not necessarily light. Usually they are light because you're not getting good proliferation and not a lot of is happening hormonally, so you don't get a lot of flow, but it technically means lengthening of the cycle, so they're infrequent. Again, the same chart. I said it last week. You're going to need to know this chart. So it's very helpful to look at it today. And it's on the second page of your handout. So you can kind of, I don't know about you guys, it helps me to see it and write on it. And just like make notes and add things here and there. So you can just jot stuff down. I thought that'd be helpful while I talk. It does some definitions you need to know, which you're probably learning with medical terminology, but menarche or menarche, some people, everybody pronounces it different. Menarche, the first period, the age of the first period, okay? Typically with young girls, if they have menarche at a normal age, 12, 13, sometimes we're seeing it in 9 and 10-year-olds now, they're usually not real heavy, they may not be real regular, it takes them a few years to kind of get their hormones rolling real good where it's real predictable. A normal flow duration is usually 4 to 6 days, but it could be 3 for some patients, it could be 7, so this is just a average, okay? Volume of blood loss, again, we've talked about how do you ask that when you're taking an HPI. You just need to ask it by how many times you're running through whatever feminine product you use. You know, are you having to change your Super Plus tampon every hour? And that's too heavy. You're getting up in the night because you're bleeding through. That's too heavy. So it's easier for girls because girls have kind of a first-hand, most girls have a first-hand experience. So it's a little easier for us to figure out how to ask it. But for men, you just need to ask kind of how you think of how you quantify that, and how you absorb the blood is a good way to quantify it, with your whatever you're using to absorb it. Normal cycle length, again, is anywhere from 21 to 35. The average is 28. Most normal cycles are every 28 days. They go with the moon. That's what they call it, the monthly. The actual word amenorrhea comes from month or moon. Interesting. Why women kind of go crazy with different moons, you know. What I do want you guys to know is that the length of the cycle, meaning if they start stretching out and things aren't happening every 28 days like they should, it's usually due to this follicular phase, not something's going wrong in the follicular phase. And what hormone is important in the follicular phase? FSH, and then estrogen, right? And then whether or not you get that LH surge depends on the estrogen also. So it's interesting that feedback loop is actually in that part of the cycle. It's a positive feedback loop. As that estrogen's being produced, it actually then causes it goes back up to the brain and tells the LH surge to happen. So it's a rare time in normal physiology when a positive feedback loop works. So if you have shorter cycles, like if you're having bleeding in between periods and cycle that's less than every 3 weeks, it's usually due to this follicular phase happening too fast, which goes with FSH pattern. You'll learn more about this in menopause, the lecture. We have a physician coming to talk about menopause. But as you get older, fewer follicles are produced each cycle, and so you start to get kind of shortening cycles, lighter cycles. But then right before menopause happens, they start to stretch out and there's few and far between until they finally putter out. So you need two things to have a normal period. Who can name them? One is on the board. Hormones. You've got to have the hormones doing what they are supposed to do to kind of orchestrate the whole thing. So you can imagine it like it's the guy up in manufacturing, like you're in a manufacturing building and the guy's like overseeing what's going on the floor. But then if you don't have the workers down below to put the stuff on the bus and send it out, you have obstruction in the outflow itself, you won't have flow either. So most of what you're going to see as run-of-the-mill general practice is going to be hormonal. It's going to be more rare to have these obstructive things happen to your patient. So just a little bit more terminology we need to know, which we brought up a minute ago. Oligomenorrhea is technically cycle lengthening. They're not happening at the regular intervals as they should. You can also have that and have them be heavy, but it's more common for them to be heavy and just be heavy, not be irregular. So menorrhagia, regular intervals but heavy bleeding. Your second part of menstrual disorders on Thursday will cover the dysfunctional uterine bleeding and heavy flow. So again, the amenorrhea means no monthly flow. What you need to know as clinicians, again, because we like to build differentials, right? We like to be real, sound real smart when we know what it's going to be. In endo, you guys learned primary versus secondary is based on what? Where the problem is, right? It is not that way for amenorrhea, okay? So this has got an asterisk by it. It is an endocrine thing, but it's primary amenorrhea means the patient has never had a period. They're 18 years old and have never bled, okay? Secondary amenorrhea means they've stopped bleeding or stopped bleeding frequently and normally. That's due to some secondary cause. What would you guys think the #1 cause of secondary amenorrhea would be? Pregnancy. So it's always the first thing you're going to check. How many lectures have told you guys that? No matter what the patient says, and especially like Dr. Gibson says, there's an older adult in the room. Just don't even have the talk or the argument. Just order the urine pregnancy. You don't even have to tell them you're doing it. Just say, we need to get a urine specimen, So always rule that out first, okay, before you do anything else. Do not pass go. Do not collect $200. Rule out pregnancy. So a new word for you guys, thalarchy, or thalarc, which I never have used. That's the development of breasts. So if they have not had a period or have had any bleeding within 5 years of breast development, that's primary amenorrhea. Okay. If they've developed other normal secondary sex characteristics, but they're not having periods within 13 to 16, well, if they have secondary sex characteristics, you give them a little bit longer, okay? You give the ovaries and the hormones a little bit longer to kind of get things rolling. But if they have no sexual development by the age of 13 to 14, you need to work it up, okay? Something, probably, what would you guess is going on? Just pulling out from a lecture I gave a long time ago. It's probably a genetic disorder of some kind. So if they are not developing, the pediatrician is going to pick that up. That's why you get those growth and development scales, and you're checking off the boxes, and you weigh them, and you get their height every time the kids go to the physician. So if they're not sexually developing by the age of, 14 is pretty late. So, I mean, 13, if they're not developing any secondary sexual characteristics, which you guys will go over in detail, then you need to work up that primary amenorrhea. If they've got breast buds, if you ask mom, and you're like, does she have some hair in her armpit, or any pubic hair growing, any fuzz starting up, then you maybe give it a couple more years and see if it'll get going. Okay. Technically, depending on what book you read, secondary amenorrhea, most people are going to say give it 6 months. Most clinicians are going to want you to just kind of, if you have a girl that comes in with no period for 3 months, you're going to get a urine pregnancy. But if it's negative, give her another month or two. You may give it up to 6 months to see if things are going to happen. Now, if the patient is adamant that they always had normal periods and now all of a sudden they are not, then you can work it up at 3 months. But I'd probably wait till 6. Or you can, if they have already been having oligomenorrhea, like they've already had, like it's been 6 months, I only had 3 periods, then you might work it up a little bit sooner. You don't have to be so strict on that you haven't bled at all for 6 months. I mean, if they've had 6 previous months of really infrequent and weird periods, and then they come in and haven't had one at all for 2 or 3 months, then you could probably work that up. Okay, you just kind of have to use your clinical judgment on that. Does that make sense? Okay, so how we're going to categorize these, so you need to think about these disorders in big chunks, okay? But you need to think about these disorders based on where the breakdown was in the chain, okay? This is kind of like all endocrine disorders. You kind of look at what went wrong and where, and how do I find out where it went wrong, which is the fun thing about kind of internal medicine and stuff like that. You just get to order labs and then look at them and interpret them. So I listed these. This is an old PowerPoint from a guest lecturer that came that works in women's health. So I just kind of tweaked it a little bit. She had them listed backwards with category 4 being the hypothalamus, but I like to think of it from this way, from top to bottom.
Very princess stuff.
Maybe this way. Maybe and I probably won't get real strict with what category was this. It's mainly just to help you guys lump them into groups. Okay. And it also here you can see the incidence based on the etiology. So 35%. So more than a third of girls that come in with this, something's going on in the hypothalamus. Okay, and that's going to come into play later when we talk about that. Anterior pituitary are going to have about 20%. Okay, usually that's due to a high prolactin level for some reason, and we'll talk about that in a little bit as well. But that's right there you've got 55% of everything going on is at the level of the brain. Okay. 40% then are going to be ovarian failure, or, the estrogen and progesterone from the ovary itself isn't working correctly. And then that's pretty much all of the things you're going to see in run-of-the-mill practices. Then you have this tiny little 5% that are outflow tract problems. Okay, so we're going to this lecture just goes through how do we work through working up a girl that comes to you with a complaint of amenorrhea. Okay, we'll go through each of these steps, and if you follow these in your practice, they're going to get you to the bottom of it eventually. Even if it takes 7 steps, you'll get there. Okay, but it's good to not don't have a patient come in and say, I've had a period in 6 months, and then you order everything. You don't order an MRI of the pituitary first time you see someone with amenorrhea. Okay, so if you'll follow these steps, it'll help you be a better investigator. So as you can imagine, which type of amenorrhea, primary or secondary, are you going to probably be able to figure out on physical exam? You're going to be able to identify a primary amenorrhea probably just by doing a good history, looking for secondary sex characteristics, asking about genitourinary abnormalities, because some of these karyotype mutations or mutations, they get other renal abnormalities as well. You want to ask them if they can smell. We'll get to that here in a little bit. You'd be like, why? Well, that's kind of interesting. So just a good history will probably identify, and then your physical exam, your pelvic exam will identify somebody who has primary amenorrhea if they have an outflow obstruction, did they never develop a uterus, things like that. Okay. For secondary, you can, in a run-of-the-mill practice, you may be able to nail that one just by looking at the patient as well, because what are we going to be looking for? Signs of androgen excess, okay? What kind of characteristics is the patient going to have if she's got too much androgen or an imbalance of androgen to estrogen? Facial hair, acne, will just kind of look more swollen. They might have a low voice like me with I was sick, you guys, over the weekend too, so whatever y'all had, I didn't have strep, but I had something, you know, I got it too. I said it's palpating those stupid breast models, I bet, after everybody was touching them. So you can look at the patient, see if they have, okay, the other thing is, what if they got like excess cortisol? What might they look like?
Round belly.
Dirty neck. Well, that's insulin, but you know, they'll have that. You'll see that clinical picture of buffalo hump, round, you know, kind of look like a linebacker. Like Dr. Gibson said, those babies with gestational diabetes come out looking like linebackers, you know. So they have an insulin resistance problem, excess androgen. You'll be able to start putting that visual picture together and maybe able to nail it before you ever do a pelvic exam. You definitely want to screen all patients who just automatically stopped bleeding. Ask them about stress, depression, screen them for, you know, I would ask them for sure if you have any signs that there could be something going on psychologically, psychosocially, delve into that a little bit more. How much do they exercise? How much do they eat? Are they skinny? Because that'll make you stop having periods as well. So, of course, you want to ask, this is where your galactorrhea question comes back into play. See, they all come together. Some of you guys forgot galactorrhea in your SPL because it is such a weird thing to ask. But if somebody's not having a menstrual period, you need to ask it, because what does that mean? They have a high prolactin level, which is how many, it causes what, 20% of amenorrhea, so ask about galactorrhea. And they may not say they're having a milky discharge, ask if they're having any kind of weird discharge from their breast, you know. Definitely past medical history when you're working this up. Past surgical is important because you need to know if they've had a prior D&C, prior pelvic surgery. Have you had some type of weird pelvic cancer and you have radiation to your pelvis? Just anything that can insult the ovary or the uterus. So the exam is extremely important for genetic problems. So for primary amenorrhea, that is a catheter in the urethra, and then there's nothing there. You have nowhere to put a speculum. So look at it, make sure there is a uterus there or not, and if you find that person needs a surgeon or a specialist of some kind, we'd be referring them on to see what they want to do about that. But they are not menstruating because they have nothing working. They have no working tract. You can also tell, like, again, with the breast development, if they have breast development, and let's say it's a PCOS looking teenager, and they really haven't bled enough to really have established good cycles, so they just really haven't ever had regular periods. Maybe they've spotted here and there, and they kind of look like a PCOS patient. Check and see, I mean, you need to check and see if there's breast development. You know, I mean, are they having, if there's breasts, then there's estrogen there. I mean, there's something's trying to happen. If they don't have breasts, then you may notice something like this go on. There's just no outflow tract. What would an FSH tell you at that point? If you were to check an FSH, you have no breast development. You don't know why estrogen's not being made. So if you check an FSH, it's going to tell you where the breakdown is. Is it breaking down at the level of the pituitary, or is it the ovary not responding? So if the ovary's not responding at all, the FSH will be high. It's trying to get it to do what it's supposed to do. So FSH is always helpful. So step number 2, you're working up your patient with no period for 3 to 6 months. Your first thing you're going to do is a pregnancy test. We either give them the good or bad news. I don't know, whichever. It depends on the situation. Okay, so throughout this, we'll go kind of down the steps. There's our first step. There's the Amenorrhea roadmap. We're at the top. So they're not pregnant. Pregnancy test is negative. What do you order now? So now you're looking at the easiest, quickest, cheapest things to rule out right off the top. Now you might be a very smart, brand new PA and have your differential already laid out. And like many of you at SPBLs, you want the answer up front. You want to order everything and I want my answer. But you can't do that. You have to know in your mind, this is probably what it is, but we're going to get to that answer in a reasonable manner. We're using a rifle, not a shotgun, right? Mm-hmm. So if you check a TSH and she's got hypothyroidism, so TSH is elevated, then you might do further thyroid workup. But just hypothyroidism itself, and it looks kind of funny, this falls into category 2, okay? Because hypothyroidism itself alters the GnRH pulsatility from the hypothalamus, and then the pituitary will not get the signal to put out the FSH. So, and it does it by means of prolactin. So you bring prolactin back in again. And trust me, I am no pathophysiologist, so I like to look at this stuff very basic, like how is this going to help me clinically? So you just kind of need to know what your steps are and why does low thyroxine and then high thyroid releasing hormone alter the hypothalamus secreting GnRH. Well, it does it via that increase in prolactin, which is kind of weird, but that's how it does it. So again, prolactin is a player in this. Prolactin is bad for periods. Why? When you're lactating, you shouldn't have a period. So again, you're going to confirm this diagnosis with your lab results, TSH, free T4. You can check thyroid antibodies to see if it's like a Hashimoto's or something like that. And then your treatment is thyroid replacement. And usually, once you treat, you correct the thyroid, you bring the thyroid releasing hormone down and get prolactin out of the picture, then normally the girl will start menstruating. Okay, so we've ruled out pregnancy, we've ruled out thyroid. What's the second part of our basic endocrinology workup? Prolactin. Now we're checking the prolactin. So if you've ruled out thyroid, now we're going to check prolactin. So, if we know the prolactin is elevated, all we know is there's hyperprolactinemia. You don't know why yet, okay? But hyperprolactinemia in and of itself will cause amenorrhea, irrelevant of what the cause of the elevated prolactin is, okay? So really you don't even need to know, you need to keep working at, okay? So what your first thing you're going to do, because you're such a good history taker, you wrote down all of the medicines the patient is currently taking. What medicines cause elevated prolactin levels? Did you guys talk about this in endo? Ones that cause galactorrhea. Prolactin, Reglan, metoclopramide. That's the one you give to women to try to get them to nurse. I've even seen them give it to women who are adopting a baby. Try to get the breasts to start secreting milk, and then you suck, and you make more milk, baby sucks, you make more milk, and then you're on a positive feedback loop. So Reglan will do that. Antipsychotics are a big one, and they can also cause gynecomastia. So usually the drugs that cause gynecomastia can also cause amenorrhea in a woman. So it's gynecomastia in a man, amenorrhea in a woman. So the other one that is why you don't hear people writing for Tagamet anymore. Tagamet is like Zantac and Pepsid. You hear Zantac, Pepsid all the time, but Tagamet or cimetidine actually can cause this too. So really people don't even use that as first line anymore either. So other one that can give men boobies when they don't want them is opioids. So long-term use of opioid medications can give you, elevate your prolactin levels, give you amenorrhea, or give men boobies. The good thing to know on this one is you do want to check it a second time to confirm that it's elevated, okay? Because prolactin can kind of be variable. So if you get an elevated prolactin level, bring them back in a week or two, check it again, confirm that it's elevated, okay? So, and here, there's a lot of good pathophys stuff in this, but I'm not going to hammer you guys on pathophys. I just want, again, I think like a clinician. I just need to know what is it doing so that I know what to do with my patient. Because if you start reading up, I mean, I could spend a month preparing for this lecture because it's fascinating. You know, all the pathophys is really fascinating. But the interesting thing on this is, as you found, have you guys talked about dopamine in psych, how it's mostly an inhibitory, inhibits a bunch of things? You may have talked about it in endo too. It's kind of inhibitory to a lot of things. Well, high prolactin increases the dopamine because dopamine wants to inhibit the prolactin, but then that messes with the G and RH. The dopamine will cause changes in the GRNH pulsatility. So the take home on that is dopamine should be kind of a general inhibitor for lots of different things, and it's one of the, prolactin is one of the ones that tries to keep in check. And so if your prolactin's high, your dopamine increases as trying to negatively feedback. Okay. So we talked about hypothyroidism can be a round indirect way to raise prolactin, right? Obviously, what's the big one that can make prolactin? It's going to be the pituitary adenoma that's actually has functional tissue that's secreting prolactin. Okay, so pituitary adenoma, and or also called prolactinoma, and then we talked about meds. Okay. I'm not going to hammer you guys on treatment for this. Obviously, you're going to get on thyroid if they're hypothyroid. Bromocriptine is the one that connect it in your mind. That's what you would give someone who's leaking milk. Did y'all talk about that in endo? You want to stop that. Bromocriptine is the way to go. You'll also see some people give bromocriptine for breast pain. But, I mean, unless it's really severe, I wouldn't do that, or unless they also have a high prolactin level. So that's another thing. If you have a lady coming in with really bad cyclical breast pain, you might check a prolactin on her, see if it's high. If it's high, you could maybe treat her with bromocriptine, but just connect treatment of galactorrhea and treatment of high prolactin with bromocriptine. And then, of course, if it's an adenoma, you got to resect it. Okay, so we've ruled out pregnancy, ruled out thyroid, we've ruled out, let's just say the prolactin's normal. Now what do we do? Now, and somebody talked about progestin challenge. I can't remember which doctor it was. It may have been Dr. Gibson. Or maybe not, I don't know. But so you challenge the system to work, okay? This is checking to see if there's adequate estrogen already in the ovary, okay? They're just not getting the right amount of progesterone to get the ball rolling down the hill, okay? If this also, let's say you have a female that's 27, has already had a pregnancy, has already had one D&C, and then now her cycles are all messed up. You've ruled out these things, pregnancy, thyroid, prolactin. Now you're like, why is this girl who used to have normal periods not having normal cycle anymore? Well, you need to know if it's estrogen related or not. So you're going to give her a progestin challenge, okay? Because it also checks to see if her outflow tract will work. So you're actually checking for estrogen, and you're checking to see if she can anatomically let blood out, okay? So if you're going to give like 10 milligrams of progestin for about 5 to 7 days, and then you withdraw the progestin and you wait. You see if it happens. So if she bleeds, you know there's estrogen there. She's likely just not ovulating, okay? So she's not having that ovulation and that corpus luteum that takes over and secretes the progesterone and then gives you a normal cycle, right? So if she bleeds in response to it, it means, number one, estrogen is there. She doesn't need exogenous estrogen. There's estrogen present, but she is not forming that corpus luteum and not having that normal cycle, okay? So it's probably, so you know she's not ovulating, it's anovulation. But you, clinically, almost always that's going to be PCOS, okay? And this is an ovary problem. So at that point, if she bleeds, okay, all right, we probably are not ovulating. There's something going on at the level of the ovary. There's estrogen there, but the orchestra is not playing at the same time. So we know she's got an ovary problem, okay? If she doesn't bleed, what do we know now? She either has, we don't know for sure, we either know she doesn't have adequate estrogen, or she's not able to bleed through her uterus, something's obstructing. So we still haven't completely ruled out obstructive stuff, okay? So then you give her a challenge of both estrogen and progesterone. Yeah.
I just have a question. So the challenge test, is there a reason why you wouldn't check just like serum estrogen progesterone levels?
At this point in the workup, I would just challenge her.
Okay.
Yeah, and there's no need to do a bunch more lab at that point. Yeah. You could, but it may be because those things are so variable throughout the cycle. But
okay.
Would you have to check it a whole bunch if you're checking estrogen and progesterone?
right, so it's easier to just see if there's adequate estrogen or not by just see it, have her show her cards.
Okay.
Do you have estrogen in your hand? Without having to draw a bunch more lab. That's a good question. I actually don't. I just know this is the way you do it. I think it's probably because the levels vary too much. It's not as accurate, probably.
Okay.
So we know if she does not bleed, now we know she either doesn't have adequate estrogen or she still has something obstructing the bleeding. So we challenge her with both estrogen and progesterone. Now we're going to give her we're going to give her a birth control pill to give her a normal cycle, basically birth control. You're going to supplement both things and withdraw it and see if she bleeds. Okay? So again, you wait, see if she bleeds. Yes?
If they have an obstruction, are they still shedding, but it's just like...
Yep, exactly. So, and that could be something that just started, like this girl, just all of a sudden over 6 months, she can't shed the blood out anymore, so it's just being retained in there. So this patient may have dysmenorrhea. She may have pain, pelvic pain, fullness, things like that as well. And if she's had a prior operation in her uterus, it's going to clue you in that it's probably something we're going to get to in a minute. But yes, it'll just retain it.
Would she not have toxic shock syndrome?
You know how really fabulously uncommon toxic shock syndrome is? I know they scare the bejesus out of everybody. Put that on the tampon box, right? And it's just rare or something, really rare. Probably has more to do with how you respond to certain bacteria in an autoimmune manner than anything. So, good question. Okay, so if you supplement estrogen and progesterone and she bleeds, now you do know what for sure. That it was an estrogen problem, right? She is not ovulating, she doesn't have adequate estrogen to get the ball rolling, okay? So that's going to take you to what you do next. But if she doesn't bleed, what have we ruled in? She has an obstructive something, okay? Because this is at this point, this is a girl this is not primary and amenorrhea. You're not going to get this far down the track with primary. This is a secondary amenorrhea at this point. And she's got something blocking her flow, okay? You do need to know some basic things that block the flow, okay? Number 2, the acquired, the one that causes secondary amenorrhea, is probably going to be Sherman Syndrome, okay? Sherman's is when, I think Ken talked about it yesterday, when you aggressively curettage the lining, the endometrial lining. If you pull off too much of that tissue when you're doing a D&C, you can actually cause scarring, okay? And so if you, and some people, and you'll find this in your practice when you got there, some people make adhesions, some don't. We don't, it's some connective tissue thing that we don't really understand. Not all people make adhesions, have the exact same procedure done, the exact same way, and they won't make adhesions, and then another person will make adhesions. So, Sherman Syndrome, again, somebody that's had a prior D&C, someone that's had some type of abortion, okay, and have had to have a D&C afterwards, whether that be elective or not. Second thing is, something we also talked about yesterday, cervical stenosis. So if you go in and do an aggressive cone biopsy and you take out a big chunk of the cervical os, and then that patient can scar that down and just create a scar that closes the cervix up. That will cause all that sloughing, that endometrium to just back up into the uterus. Okay? So those are your 2 big acquired or causes of amenorrhea in somebody that was having periods and now is not, as far as a physical obstruction, okay? Now, congenital reasons, these people are not going to probably come into your clinic. This is going to be something you're going to pick up on your physical exam. You're going to see something doesn't look right. You're going to, a pediatrician might note this, and or the patient will start to menstruate because their hormones are working, and because they have a vaginal septum blocking it, or because they have an imperfect hymen, they get pain. And these patients will usually present with really painful periods. I don't teach embryology, but there is some reason why the septum forms, okay? I'm not going to test you on it, but that's what it looks like. It just, honestly, it just has a block about 2/3 the way into the vagina, okay? Something doesn't split where it's supposed to split. That's my lecture on embryology. This one, something doesn't split. Other places, something doesn't close. This one doesn't split. And then an imperfect hymen. Did you guys talk about that in anatomy, the hymen? So, everybody knows the crude way that we talk about this, right? You know, what they equate it to, what fruit they equate it to. But it should have holes in it, okay? It should allow the blood to pass out. There should be perforations in the hymen allowing some blood to come out, and then eventually it just it goes away, especially after sexual intercourse. Of course, the hymen will cease to exist. but it should have at least a hole for blood to come out. So if it does not, if it's imperforate, then what's gonna happen? It's gonna fill up in there. And that'll be uncomfortable, because this is filling up in the vagina, you know. Asherman's, just have it in your brain, scarring, usually due to aggressive curettage. Know that when you see a prior DNC on a patient's past medical history, that is connected with Sherman Syndrome. But it is it's adhesions. You diagnose these by imaging it in some way. Okay. And then of course treatment is surgical. Send them to Dr. Gibson. Okay, so we've ruled out pregnancy, ruled out hypothyroid, ruled out prolactin. We've challenged them. We've challenged them both ways. Now where the heck are we? Is everybody as lost as I was when I first looked at this lecture? You have to study. Once y'all study this is going to that makes total sense, but just bear with me. Okay, so she bleeds. You give her estrogen and progesterone, and she bleeds. So we know it's not obstructive. She can bleed. She just needed that final piece to the puzzle, the estrogen, okay? Well, don't you want to know why? Why does she not have adequate estrogen? So now you start looking at FSH levels, okay? So you check your FSH, and the FSH is high, and I already have it on here. What does that tell you? If your FSH is high, but your ovary's not listening. Your ovary's not making the estrogen. It's being told to, it's not cooperating. So something's going on at the level of the ovary, okay? At that point, you're going to need to check for genetic stuff going on, okay? If the FSH is low, now what do we know? Something going on up top, okay? The ovary's not getting the signal, okay? So again, we haven't really checked estrogen levels at all. We've just indirectly evaluated the estrogen, the function of the estrogen. So now we're going to look at her brain. Okay? Well, finally, step 6, we get to MRI, right? Okay. So let's talk a little bit about the ovarian, the reasons the ovary doesn't cooperate. Okay? We just like to call that premature ovarian insufficiency or premature ovarian failure. Okay, something within the cells is not secreting the estrogen. Okay, so their hypothalamus, their GnRH is being secreted by the hypothalamus. The FSH and LH are being secreted by the pituitary, but the ovary is not getting the message and not cooperating. So this was on her slide, I kind of thought it was cute. I put the ovary on the face. So again, just think, if the FSH is high, it's because the pituitary is trying to get its message across and the ovary is not cooperating. So when else would you start to see FSH levels go high that's not necessarily pathologic? Menopause. You know, start to see that ovary's finally spent all of its good eggs and it doesn't have anything else to give. So FSH is tossing it around and it can't do it. Okay, so why you want to check the karyotype? Now I hope, being OCU trained physician assistants out there, you're going to recognize Turner syndrome, okay? Because we talked about it. Yeah. The neck, the webbing, the elbows, the lack of sexual, secondary sexual characteristics. So you're gonna see these kids. We're way down the roadmap, but you're gonna catch this probably earlier, like we talked about in your physical exam early on. You're gonna catch this stuff. So you can check a karyotype, which will tell you they have Turner syndrome. You can actually check a Fragile X DNA test, which will confirm or rule that out. You can also have androgen insensitivity syndrome. So this is the original transgender. I mean, this was like, this boy is XY, born a boy, but his, for some reason, genetically, a mutation occurs and his androgen receptors turn off. So he's responding to the estrogen, but not responding to the testosterone, and so he, on the outside, looks like a girl. So bringing it into current things that we see in society, there's a whole, we don't know what genes are at play there. We may find out at some point that there's, when we start identifying more and more and more genes, there may be a spectrum of this type of thing going on, you know, where you don't necessarily have an X and Y, but you are not sensitive to your estrogens or your androgens, and you tend to lean the other way, even though you have the sex characteristics of your XY or XX. Okay. So these patients, again, don't develop a penis. They sometimes develop a gigantic clitoris. So when we say you guys are supposed to look for clitoral enlargement, that's like, why? What is that like a thing? Do people do that? But if they have androgen excess, they'll get clitoral enlargement. So if you have androgen insensitivity and you're supposed to be a boy, you just won't develop it. You won't develop the outer stuff that should. And most of these boys have undescended testes too. They'll like have testes instead of ovaries, but they're kind of where ovaries should be. So I think this is what I've heard rumorings of Jamie Lee Curtis having. Did you guys
just looked that up.
Yeah. So
Does she have?
yeah. Maybe you all heard that she's a hermaphrodite or whatever, but she has androgen sensitivity syndrome, so she really is an XY.
Yeah.
Wait, does she actually have that, or is it disappeared?
I mean, I don't know, good.
That's the truth. It's true.
I didn't look it up, but y'all can. Okay, so the genetic things that cause the ovary to not do what it's supposed to do, we talked about. Okay, now what secondary things can cause the ovary to not cooperate could be full-on autoimmune attack. It would be polyglandular. You may have thyroid stuff going on, ovary stuff going on, adrenal stuff going on. So that's a workup for a specialist, but you need to know that that can be a cause of the ovaries to not cooperate. Okay. And then there's, of course, that you've been radiated. I mean, you've had a colon cancer, you're at 35, you get a colon cancer. You don't want to radiate colon cancers, that's probably bad. But you had, let's say, cervical cancer or something, and you had some radiation, you know, and secondarily you injure the ovaries, and the ovaries are beat up and sad. Different chemotherapeutic agents too can cause ovarian failure. So why do we call this hypergonadotropic hypogonadism?
High level of GM.
Hyper FSH, yeah. So the gonadotropic releasing, that's happening, but you got hypogonads. Hypogonadotropic, hypogonadism, they're both low. Okay, so we know the problem's at the top. So to think about these clinically, you have all we know at this point is they have an elevated FSH, right? Okay. If we go back, oh wait, no, hang on. Let's go back to our, okay, so we're here, okay? Now we have a low FSH. I'm sorry, I misspoke. Okay, so FSH is high, we looked at the ovary not cooperating. Okay, the FSH is low, we know it's up top, okay? That's where we're gonna get an MRI of the head. Okay, so this time we've got decreased stuff all across the board. But we know what's going on at the hypothalamus or the pituitary gland itself. You would get, at this point, this stage of the game, you get the MRI, okay? Most commonly it's going to be, now you may not have picked this up on the prolactin, like what your prolactin earlier was normal, but we still don't know what's going on. You'll catch it here. So you actually have two stops to screen for pituitary adenomas, okay? So if we didn't pick it up on the prolactin level, you'll pick it up here with this MRI, okay? When you order this MRI, you do need to have them tell them, again, the radiologist wants to know what you're looking for. Don't just order MRI of the brain. Is it a stroke patient? Is it MS? Are you looking for MS? And what are we doing? Tell them attention to the cella turcica, so they know that you want them to pay attention to the pituitary gland. There can be some brain tumors that are associated with this. There's one in particular that I got to reading too much about, and I was like, okay, we got to stop that. Because it specifically, it goes right there where the pituitary gland is. Okay, and I'll tell you the name of that one in a minute. And then you just have good old-fashioned hypothalamic dysfunction, which is going to be the majority of these. And then you can actually inherit things that cause the hypothalamus to not do what it's supposed to do. We'll talk about that in a minute. So most of these are going to be prolactinomas, okay? You've gotten this far down the roadmap. You didn't catch the high prolactin level. There wasn't a high prolactin level, but now we have a prolactinoma growing. That's a 1 in 10 ladies with amenorrhea have a prolactinoma, so that's a fair amount. You'd be thinking about it, okay? You rule that in or out with that MRI. So it may not secrete prolactin, may not have hyperprolactinemia. You may have signs of acromegaly. You may have signs of Cushing's disease. So at that point, if you're just looking for the tumor itself, you don't necessarily know if it may not be functional at all. You guys talked about that, right, with adenomas. It may not really even secrete hormone. It may just get in there and bully everybody out of the way and not let everybody do their job. So at this point, though, you've got it narrowed down. Okay, if something's growing, they go to a specialist. Okay. If you want to be really smart and check for acromegaly and Cushing's disease, do it. Did we talk about Sheehan's syndrome? Okay, so, pretty rare, but it's loves to be on the board questions. I think we were talking about, I think it was Dr. Gibson said she hasn't seen it maybe once. But massive hemorrhage postpartum, severe hypotension, loss of blood, hypovolemia. The pituitary stalk actually gets ischemic, then you feed the tissue, and so you get hypopituitarism. So we love to test you guys on those kind of things. You can get infiltrative things. Tuberculosis has been known to do this, sarcoidosis, but again, these are things that are rare, okay? You're not going to see that problem. And then there's the special brain tumor that can cause problems with amenorrhea because of invading into that area of the pituitary. It's that craniopharyngium. It's like a blood vessel growth in there. So, for those of you who want to be on Jeopardy someday, there you go. All right. Most of what you're going to see, this is all fun to work up, right? You've gone through this whole thing and everything's been negative. Guess what it is? It's hypothalamic, so it's weight, starving themselves, super stressed out. Typically anorexia, not bulimia, or anorexia, just a state of starvation, will do this. Excessive exercise. They're training for a marathon, training for a triathlon, they've lost 30 pounds, they're exercising too much. The body, it goes into protection mode. We don't want to have a baby. But if you're not, it's amazing how you have all these backup systems to prevent harm to the primary person. You know, your uterus does not want to house a baby when it isn't getting enough food for itself, for its own human. Does that make sense? I mean, it makes sense to me. So, eat. Stress in and of itself, though, without starvation, stress can cause you to quit menstruating because of what magical hormone of stress? Cortisol. Right. Cortisol directly disrupts gonadotropin releasing hormone. Okay, like just right there, disrupts it. Excessive exercise by way of stress, those two things kind of feed off each other. So excessive exercise can cause this, but then as you see down there, excessive exercise also increases the endorphins, which alters gonadotropin releasing hormone. Okay. So the female athlete triad comes into play there. They've lost too much weight, they're stressing themselves out, okay, not eating adequate amounts for what they're putting out energy-wise. And then the one that'll be on board exams maybe is the one weird syndrome you need to know is the Kallman syndrome, okay? It actually is a cause of primary amenorrhea because it is an X-linked genetic problem, and this is the one that patients will also not be able to smell. Weird, okay? They lack a gene that codes for a protein that causes these adhesion molecules to work. Don't ask me how, but that specific type of adhesion molecule affects the hypothalamus, how those neurotransmitters and those neurons migrate out to release their stuff out, and it affects the olfactory nerve as well. So they can't. If they're not having periods and they can't smell, you're like, oh, I know it. That's common syndrome. All right. That's a lot of information. That's your big one there. Is, again, like we talked about at the beginning, patients aren't going to go from 28 days, 28 days, 28 days, 28 days, and then they don't have a period for 3 months. That usually doesn't happen. It's usually pregnancy. Okay? So, to summarize, let's see if you guys remember along with me. What hormone is released here? Hypothalamus. Okay. What does the pituitary release? Okay. What does ovary make? Okay. Which part makes what?
Follicular something.
Right.
Did y'all learn estrogen?